Hi, good evening, everyone. It's very cold here in Assam, and that's why I'm very much geared up. Okay, so not going into a lot of personal talks, but I want to yet tell you that whatever I'm going to speak today about interdisciplinary team and the palliative care delivery models or systems that we have here in India, everything has got a lot of personal touch, personal relationships to be developed with yourself, with your, colleagues, with your team members, to deliver the best possible care to your patients. So I'm just wanting to share my screen. Yeah, is that okay? Everybody can see my screen?
Yes, ma'am. Yes, perfect. Oh.
Great. So, right. So, we're going to talk about palliative care delivery and interdisciplinary team. And there'll be a lot of, do not have much pictures to show you, but then I would, try to give you examples and then elaborate on how these things actually work when the intention is to give the best possible care to our patients. Okay. So what is a team per se? What is a team? So it's a small number of people with complementary skills who are committed to a common purpose, performance goals, and approach for which they hold themselves mutually accountable. So it is as simple as that. This is a very simple kind of a definition of a team. But having said this, there's a term in palliative care which is called interdisciplinary team. So this is described as an identified collective in which the members share common team goals and work independently in planning, problem solving, decision making, and implementing and evaluating the team related tasks. Now, interdisciplinary team for in the context of palliative care is extremely important. It's a very important thing. As you can see in the definition, it is an identified collective, which means that the members of the interdisciplinary team, they are being identified and taken into the team. That is one point. And they will share common team goals. So if there are 3 members, if there are 2 members, if there are 5, 6 members, all of them will have common goals, and even when they have common goals, they would work independently for planning. They can, work independently for problem solving, decision making, and then implementing and evaluating the tasks that are being identified. Having said this, in palliative care, as of now also, the world has actually gone, too far in defining palliative care, or in defining the usage of palliative care, the importance of palliative care. But then, when we talk about delivering delivering the best possible care to our patients, sometimes in one corner of the world, we find ourselves very lonely. I, as a physician, 10 years back, was just the only person working for palliative care. I didn't have a team per se. But then the Oxford textbook of palliative medicine also defines this particular system as a solo practitioner model. So the importance of this particular statement is that if you are working solo, you don't have a team, please do not get disheartened, because you are the one who is practicing a solo practitioner model. Okay, you may be a social worker, you may be a nurse, or you may be a physician, or you may be a physiotherapist, you may be a nutritionist or a dietitian, you may be a yoga practitioner, but then you have you have the heart to deliver palliative care. So you are actually trying to give some solace, you're trying to deliver good quality care to a patient who needs palliative care, and you've started it. That means that you are a solo practitioner model person. Okay, and slowly, when when you see that there are people in and around you who have identified your work, your commitment, they would actually come and join you, and then you start building up your own team. So what are the objectives of an interdisciplinary team? So it's an accurate and speedy assessment. When we say assessment, it is assessment of the person, of the patient in question. At the same time, assessing the family also. We do not generally take out the family and do only work with the patient. It is the family which is also included. And then finding out an effective integrated treatment and care, communicating efficiently with the patient and the family and with other professionals, okay, institutions, and within the team itself. So you need to communicate effectively, not only with the patient and the family, but with also other professionals who can contribute to the care or treatment of that particular patient. You may need to liaise, or you may need to approach institutions who have proper setups to take care of such patients, and then developing the communication within the team members itself. Okay, and last but not the least, the audit of the team activities and the outcomes. We need to find out where we stand. Okay, that is the reason why we need to audit our own work, our own activities. Okay, so it may be a clinical audit, or it may be some non-clinical audit, also audit of what you have been doing, how much the cost of your activities, or your perhaps if you have started with a home care service, what is the cost that has been incurred, and what kind of care actually you have given. And that is the feedback that you get from this. Hello? Yeah. So what is the kind of feedback that you're getting from other families or the patients themselves about your activities? So you need to audit everything. Then only you can actually find out where you stand and how you can improve. Okay. So this is a very interesting slide, and I really get excited when I talk about this, because we, as we work in teams in different, areas of our lives, we go through these stages of development of a team. So it's very important for all of us to know, because of two reasons. One, we can actually anticipate which stage we are in, and what we are going to face in the future, and how we are going to tackle them. Okay, so that is one. And secondly, when we know when we can anticipate properly, we already try out some strategy to curtail the bad effects of that particular anticipation. Okay, so you can see this is a small kind of a graph where the y-axis shows effectiveness of the team, and the x-axis is the time. So the team effectiveness increases with time. That is the whole sole, kind of conclusion that we can get from this. But having said this, there are around 4 to 5 stages of team development, and essentially, a team takes some time to get mature and then perform to the best of its ability. Okay. So what happens in the first stage is that there is a forming stage, or it's called the coming together of people. So, perhaps the leadership of the organization, or, it has been mandated from your department that this particular 3 people or 4 people would come together, and from now on, will be mandated to work in a team. Okay, so that is called coming together. And at this point of time, at the formation of this stage of team development, everybody has the will to deliver, to do something. The energy levels are extremely high for everyone. They have got their own strategies at the back of their mind. They want to give it their best. They want to perform to the best of their ability, because the main goal of everybody coming together is to give the best possible care to this patient. Okay, but then they also come with their own share of disadvantages, their own share of bias, as I would say, and some sort of perhaps fixed ideas that they might have had because of their own backgrounds of education or teaching, or perhaps experience in the past. But the intention for everybody to come together is very, very pure, very, very good. Okay. Now, what happens is that they slowly start experiencing some kind of conflict. They start disagreeing on matters which might be very trivial, which might be very, very, very minimal. Okay. But then the conflicts would actually pile up, and it would give us kind of a picture where they really don't want to be together. Perhaps the nurse in the team would think, oh my God, I'm working with a doctor who doesn't know anything, is not at all sincere, is not really thinking on how to give the best possible care to this patient. The doctor might think that, this nurse is so inexperienced. Why did the management even think of teaming up this particular nurse with me? So, this is a storming kind of a phase. This is extremely turbulent, and everybody would actually, complain. Everybody would be always, in an anxiety. The people, when they go back home, next day when they get up, they would actually start thinking, oh my God, again the same doctor. Oh my God, again the same nurse, the same kind of topics, the same kind of, why am I at all in this, team? I really don't want to do this, So this is a kind of experiencing conflict, or the stage of storming. As you can see in this graph, the performance of the team, or the effectiveness of the team, is at its lowest. They do not perform at all. They are not at all effective. They start feeling really, really bad about everything that is going on. And but then, slowly, since it is a developmental stage, since the team has to go through this particular stage, the stage generally, the storming and the conflicts generally calm down. A little bit of understanding start developing among the team members. And there would be one instance, in the team, or, one particular moment or one particular incidence that might trigger the phase of norming of this team development. Okay. For example, if suppose there's a patient, okay, and the home care team has been advised to go for a home care to this particular patient, and you all gear up for this patient's care. You go and find that the patient has a very bad head and neck cancer, maybe a cancer of the buccal mucosa, where the whole cheek has given way. You can see the tongue inside. There'd be saliva that is drooling. There is a lot of bad smell of that particular wound, and you all really feel so bad. Looking at the patient. This is the time where you would really want to help the patient as palliative care professionals. And, something happens, something inside of you actually prompts you to take your own roles, and the doctor, starts getting busier about asking how the patient is feeling, what are the physical problems that the patient is having, how is the pain of the patient. And at the same time, interestingly, the nurse also takes the role that she is required to, and she would actually ask the patient about how he's getting his feeds. He starts thinking about how to reduce the drooling of the saliva, how to dress the wound, so that the the foul smell actually goes off. And at the same time, the social worker or the counselor, if he or she is there in the team, the counselor would actually, understands that I have to talk to the family about this, what they must be going through. I have to ease their pain. So, this is a kind of an automatic thing that goes on. And at the end of it, when you've all done your roles, when you have, collectively worked for the betterment of the patient, you have given relief to the patient, and then you come back to your office or your center, lay yourself back and think about what you have done today. The doctor starts appreciating the work of the nurse. It is absolutely automatic, The nurse actually thinks, oh, what a wonderful doctor he is, or she is, the medications have helped the patient so much, and the social worker is thinking, I'm in the best possible company, because they have taken care of the patient. I am able to take care of the situation that the family was in. We were so good at working and delivering it to the patient and the family. So that is the norming stage, where you, the complementing efforts of your colleagues, you recognize it, and everybody in the team starts, appreciating each other's work. And that stage is called norming or normalizing. You understand how to make it work. You find a way to work together. Okay. So that particular stage is extremely, extremely important in improving the effectiveness of the team. And this generally lasts for a long time. And when the maturity is such that you all start thinking or concentrating on how to perform better. You try to discuss things with each other and find the best possible way to help a patient. You know that the common goal is to take care of the patient, and you start complementing each other, performing working effectively and efficiently. I don't want to go to the last stage because it's disbanding the team is a kind of a, it's a managerial term. But, having said this, performing, norming, storming, forming, these are the 4 important stages of team development. If you know these stages, if you are in a new team and you're mature enough to lead the team, as a natural leader or as a leader who has been appointed, then you would be able to understand the forming, storming, norming, and performing stages. And that will actually help in, reducing the storming stage as much as possible. Okay, so this is about the stages of team development. Now, what are the characteristics of an effective teamwork? Basically, there are three categories. One is organizational structure, another one is the individual contribution, and the team processes. Coming to the organizational structure, so the organization who's responsible for bringing out the home care team or the palliative care team must have a clear purpose, which is very, very important. And as a palliative care organization, our purpose is to, give the best possible care and relief to our patients, who are perhaps in the terminal stage of their lives, who are at the end of their lives. Okay. So the organization also develops an appropriate culture of, building trust, complementing people, complementing each other's effectiveness of work. We have a specified task given to us by the organization. We have distinct roles to play. For example, the physician would play his own role, the nurse would play their roles, the managerial people will also be playing their roles. There would be a suitable leadership, and the leadership has to be a one which is acceptable by the hierarchy of the system, hierarchy of the organization. And whenever you have a suitable leadership, you'll definitely have a great team working for the, the organizational goal, which is definitely patient care. And then, of course, you have relevant members, you have extended teams also, and last but not the least, must have adequate resources to deliver also. Okay. Coming to individual contribution, the individual actually makes up the organization. Okay, so the individual has to have good amount of self-knowledge, a control over his or her own subject, and then the trust that he or she has upon the organization, as well as the colleagues that are that individual is working with, the commitment to perform, to deliver, to give it the best for achieving the major organizational goals. And then be flexible. When I talk about flexibility, I am a physician, and I cannot be rigid in my ideas. In palliative care, rigidity doesn't work. We have to be flexible all the time, because something that is known to the nurse may not be known to me. Something that is known to the social worker or the counselor or the dietitian, I may not know it. And I must respect that particular feeling. I must respect that thing. If I do not do that, I am not at all flexible. I cannot be malleable. And the whole, disadvantage will be upon delivering the best possible care to the patient. Okay, so we all need to be flexible all the time. It's like a jigsaw puzzle where you try to fix in everything on the fixture which is made for it. Okay, so you have to be flexible all the time. And then team process, there has to be a lot of coordination among the team members, adequate and effective communication. There has to be cohesiveness. Okay, you have to bond with your team members. You have to bond with people. You have to show an example of bonding to other people, so that they are also attracted to that bond. Okay, and then the importance of decision making, conflict management, social relationships, performance feedback. These are all team processes which need to be assessed from time to time. And then the measurables are measured at the point of at a point where that there is a little bit of stagnation in your work. That means something has not been happening. You must try to understand that particular stage. It's not like we have been working great, so it is like that. No, there has to be a change all the time when the team processes are being measured. So this brings us to the important topic of what a palliative care team is. Okay, so we all have come to know that teamwork is an inherent feature of palliative care. Palliative care cannot be delivered without teamwork. Okay, except when you are a sole practitioner, definitely. But then at one point of time, you must must be working under a team, inside a team. So teamwork is an inherent feature. And essentially, the interdisciplinary team has its own characteristics and challenges. And the team should be both defined and flexible. And when I say defined, there would be a core team where there has to be a nurse, essentially, physician, essentially, and then flexibility about getting a social worker or a chaplain or a pastoral worker or a therapist, and then many other people which the team might find it important to include. Okay, so that's a core team. And then the extended team of psychologists, physiotherapists, occupational therapists, dietitian, nutritionist. So everything will go, the list can be actually endless. Coming on to the specialist palliative care delivered by a specialist or a consultant in palliative care, along with oncology consultant, a neurology person, a neurosurgeon, somebody who's a specialist in respiratory issues, a cardiologist perhaps, even a cardiac surgeon, a nephrologist, etc., etc. Okay. So this is about the palliative care team. This brings us to the question whether the patient and the family members are also a team member. Okay. So if you have done your previous classes or previous sessions, you must have come to know that palliative medicine is always a patient-centered business. It cannot be just medicine. It has to be patient-centered. Whatever we do, the patient is at the core of it. Okay. So All treatment must be given with the patient's consent and in accordance to with his wishes and his knowledge. You have to give him information. Okay, so the patient must be considered part of the team, and at the same time, the family members have an important role to play in the overall care of the patient. If you do not include the family members, if you do not include the patient, you will keep on hammering your kind of goal on the patient and the family members, and nothing, you're not going to get anything out of it. Okay, so their opinions should be included when you formulate a plan of treatment and care for that particular patient. And it it applies to the fact that for every patient, the treatment and the care process is tailor-made. This is the reason why it is called a tailor-made thing. Now, the IDT members, interdisciplinary team members, the whole list is actually endless. You can keep on adding to all these people. There should be a chaplain. You can include a chaplain or a pastoral worker or a pandit for that reason. Occupational therapist, a music therapist. Nowadays, the inclusion of a music therapist, a dance therapist, and for children, bringing in somebody who can encourage children to bring out their innermost feelings. Music and art, is very important. If anybody of you have had an experience of working with children, whether they are autistic children or they are cancer patients, or children with hemophilia or thalassemia, you may have come across the kind of music therapy and art therapy, dance therapy that are required to bring out the innermost feelings of children. Children cannot verbalize their thoughts. They think something and they land up saying something else. So they just can't verbalize. And we as adults, many times we are unable to catch what they're trying to tell us. It needs a lot of training for that. And the music and the dance and the art forms are extremely, extremely important and time proven. And, there is evidence that these three therapies work wonders for children to bring out or verbalize or, bring out their feelings on paper. Okay, so do consider these three things when you work with children. And of course, we all know about how important physiotherapy is, how important a dietitian and a nutritionist. But having said this, we also have to be very careful because, I don't want our physiotherapists to give something which is very, very, tough for a patient who has bone metastasis. He will actually land up in giving pathological fractures to that particular patient. Or, we all know that, my patient who's a cancer patient, terminally cancer patient, is maybe going to die after another 6 months. You prognosticate that. And then you try to give him all sort of protein powders and, a kind of a huge list of diet to this particular patient and give him all sort of, gyan that you're not eating. My dear, if you're not eating, how are you going to gain weight? The dietitian or the nutrition has to undergo a preliminary palliative care training to understand that terminally ill patients, at least the terminally ill cancer patients, are not in the stage to eat. It is a process determined by the biological process of the cancer inside the body, which is, actually depriving the patient to eat. It is related to the pituitary gland and its work. So we have to understand. And our nutritionist or a dietitian who's included in the palliative care team must undergo these trainings. Okay, so it's important that it's okay to have a lot of members in the interdisciplinary team, but we have to take, we must be careful about what we do for our patients. Okay, we have to check on our work. It is not always advisable to keep on talking to your patient, giving him all the gyan. It is also important that we devote 90% of our work, 90% of our time in listening to what they have to say. Okay, so it is that important. So there are different settings for palliative care delivery. I would deliver my care right at the home of the patient, in his room, in his own comfortable surroundings. At the same time, if my patient is able to come to the outpatient facility, he's most welcome. And if he's not able to come, then of course, I can rotate my home care team to actually go and have a visit in the patient's home. And, when I practice palliative care out here in my setups, I make it a point to do a lot of virtual communications or virtual consultations with the patient and the family. It has worked wonderfully during the lockdown period. And, it has also shown importance, and there are a lot of advantages also when you do it from your own consulting room. So it's okay that you're not actually able to examine, but then examining the patient every time may not be mandatory also, unless and until there is a new development in the patient's physical status. Okay. There are a lot of daycare centers nowadays, mostly, oncology daycare centers, but we can also, do palliative care in daycare centers. A patient can be brought to the daycare center, he can spend the whole day in that centers. Of course, if the patient is mobile, definitely mobile, not imminently dying, but then of course, diagnosed with something which is terminal. In the West, it is absolutely, very rampant. The daycare centers are very rampant. When I was doing my, training in St. Christopher's Hospice, they have a center called the Anniversaries, Special Center. So they have these patients coming in from all parts of the city, and they would come and spend the whole day there. They would be given everything that they want, and they will have a kind of a celebration in the daycare center. So we can think about many things when we talk about daycare centers. Coming to a more specialized forms, for example, if the patient is in a ICU setup for some kind of problem that has acutely set in, and the patient had to be, for some reason, had to be admitted inside the ICU, you can actually deliver palliative care in the acute care facility. Okay. And then the specialist palliative care units, which are developed solely to provide specialist palliative care to our patients. And then we all know about hospice. We all know about hospice care. Okay. So just to elaborate a little bit on the home care teams, they provide specialist advice and work alongside the community personnel. In the southern part of India, the community-based home care is extremely rampant. It is very famous throughout India. Pallium India has their own, community link centers through which they work. The home care teams actually, get a link or collaborate with the community people, community personnel that are in remote areas and provide specialist palliative care to people staying at homes. Okay. These community personnel may be volunteers, they may be social workers, they may also be physiotherapists, they may be local general practitioners. Local general practitioners or doctors are extremely important links between the palliative care center and the community where they are based in, because perhaps a patient would actually go to this particular doctor for a very trivial reason, but then on investigation they found out that the whole thing has been diagnosed as a terminal cancer, or perhaps amyotrophic lateral sclerosis, or so many other terminal disease. Okay. And that general practitioner, if you are in a good relationship with local general practitioners, you get to see those patients from your own center. You can start working with your general practitioners in remote areas and get give those people, those patients, the kind of care that is required. And that can be done through these volunteers, social workers, physiotherapists, and local practitioners. Okay. And then, of course, these community workers, they generally coordinate the care of the patients, and they form a bridge between the specialist palliative care team and the home care team also. So home care has its own advantages and disadvantages. There are many advantages. For example, there are many studies in the literature who tell you that more than 70% of our patients, they would prefer to die at home. I myself would prefer to die in my home, surrounded by my children, my grandchildren, in my comfort, of my own room, with familiar surroundings, and not surrounded by nurses or doctors or in the ICU. Okay. So 70% of our patients, they prefer to die at home. Okay. There would be more autonomy, privacy, and freedom. And it is definitely a feel safe thing at your own home setup. Okay. The family can actually anticipate the loss, because the patient is at home since maybe 2 or 3 months, have been bedridden. Somebody has been taking care of this patient. And as they see, even if they are not medical people, medical personnel, it gives them a sense of satisfaction that they're able to, accept the fact that their loved one is perhaps deteriorating day by day, and death can be imminent in a very short time. So it gives the family a sense of acceptance for the death of that particular patient, and they can accept that as a normal process of life. Okay. It is not like they're fighting it out at home. No, they are accepting that this is also a normal process of life, and then a better bereavement for this family as a whole. And as it is absolutely evident, it reduces the cost of care. There is no hospitalization. There's the unnecessary hospitalizations are prevented from happening, and so unnecessary deaths, institutionalized deaths of these unfortunate patients. Okay, so these are the advantages. Coming to the disadvantages also, home care may be difficult or impossible if the patient doesn't want it. if there is a patient who has not accepted terminality as his condition, as might happen with a very young patient, okay, who has 4 or 5 people to look after, maybe 2 little kids, a mother of 2 little kids, she would never want to die. She would never want to accept that I'm going to die leaving my children alone. So those type of patients would actually want themselves to be saved, and then they would wish that I want to go to a better facility where my life can be saved, not for me, but for my children. Okay. So those type of patients, home care is just impossible. And at the same time, there may be patient who lives actually very, very far off from that particular center. Okay. So you just cannot, complete a home care in just one day. You have to justify your funds also, your resources also. You just can't go and have take care of just one patient and come back. Okay. So those patients who live far off, they may not fall under the criteria of getting a home care. And at the same time, patients with high symptom burden, for example, continuous vomiting or unmanaged or uncontrolled pain, those patients may need, a more of a skilled or specialized palliative care doctors to be by their side, and they may not be fit for home care also. Okay. At the same time, there may be conditions where the family is physically or emotionally tired. They just cannot do it because the husband is also working, the wife has to go to the school, the kids are not, they cannot be left alone, and there's a terminal patient as at home. They are unable to deal with this situation that has come up. Somebody has to be there with this particular patient, with this father or the mother who's bedridden, and nobody, for the sake of living, they do not really have the time to do that. So those patients would actually be, going not very fit for home-based care. At the same time, as we said, they cannot meet with minimal comfort needs. The burden of care generally shifts from the caregiver, from the team to the caregiver. Okay, so this particular Rajlakshmi, can you give me just 1 minute? I have a call.
Yes, ma'am, please.
Okay, so last but not the least, the burden of care actually shifts from the caregiver, from the team to the caregiver. So perhaps this is this only person in the house, generally the lady of the house, who's actually taking care of the food, taking care of the children to take them to the school, doing all the household chores, and then at the last but not the least, taking care of the patient who is at home. Okay, so she's absolutely overburdened with all kind of work. So that becomes difficult for her to, take it all the while. And hence, that particular patient may not be a good candidate for home care. So these are real pictures of terminal patients and home care. You can see on the left hand side kind of a walker has been given to this patient who has perhaps lost one of his limbs, and then on the right hand side a terminal patient who's perhaps going to die in a few days or a few weeks time. So this patient has been taken care. Outpatient facilities also have their own share of advantages and disadvantages. In advantages, the patient can have a consultation from a multidisciplinary team because the patient comes to the facility itself. The facility may have everybody from the multidisciplinary team point of view. Okay? And they can have if the palliative physician wants this patient to have a consultation with a nephrology consultant for some kidney problem, he can always be referred. Okay. It can also happen that the patient needs some little bit of physiotherapy, and he can be referred to the physiotherapist, and he can actually go to that therapy. Then there would be family meetings, counselings, support group activities that can happen in the same place, and it's very therapeutic because most of the time, we see in our cancer hospitals that, the people, the patients would be actually, gathered in one particular space, and they start interacting with each other. And it's very therapeutic. They start sharing everything, what has happened, how did the treatment go, somebody who's died. So all these things happen, that may be informal meetings also, but you can actually formalize them into support group activities also through your social worker or counselors. Okay. And in case of severely symptomatic patients, symptoms that have not been controlled, a kind of a daycare symptom control can be easily arranged in the outpatient facility. But then coming to the disadvantages, the patients may have to wait in long queues in the OPDs. If this is a very common scenario in our general hospitals. I'm from Assam, and many of our patients, they go for their treatment in Mumbai or Chennai, okay, and sometimes in Delhi AIMS also, and they have to wait for a long time in queues in the OPDs, okay, to get the appointment of a doctor to be examined by the doctor. And that's a huge disadvantage, okay. There are space issues also. Severely symptomatic patients, they may require a more comfortable space, and because of a cramped up situation in the hospital, you may not find a good comfortable space for these patients. And then consultants from all the disciplines, they may not be available on the same day, and you may have to repeatedly go and to get the desired consultant, you may have to repeat your visits. So this is the outpatient facility. And then daycare centers, in our daycare centers, we can actually very nicely achieve good symptom control by keeping the patient under close monitoring. And this is particularly true for patients who come with severe pain and, patients with very bilious kind of vomiting or uncontrollable vomiting. You can actually put them in your daycare center, observe the patient for that particular period of time. And then in the evening, you can actually discharge the patient back home with the important medications that are needed. And but then there are also disadvantages, like, you can see in the picture that it's a world-class kind of a facility. Things seem to be very expensive. The medications may also be expensive. So it may not be cost effective for patients. Okay. The treating team may admit only those who are not in the end of life. For example, the hospitals, they may be pro-palliative, but many hospital managements would not want patients who are at the end of life to be admitted in their centers, unless, the patient dies and, there is a kind of the death register increases in number for that particular hospital. So these are certain taboos that are actually with the daycare centers also. Acute care facilities, the neurological semi and unconscious patients, patients with acute breathlessness, the neurosurgical patients, the cardiac care unit patients, they all need acute care facilities. And basically, they are in the intensive care units or the high density care units. Okay. So palliative care can also be delivered very effectively, but in adjunct to the primary consultant, who might be a neurologist or a neurosurgeon or a cardiac care surgeon or a cardiologist. Okay. So these facilities we have right now in a kind of a very premature stage, I should say, because even intensive care unit people do not want palliative care to come into their ICUs. Okay, that's the truth. Like, and then you have the specialist palliative care unit where everybody in the team, a nurse, counselor, the doctors and the specialists, they are all trained in palliative care. And the main thing that is to be remembered here is it functions generally as a inpatient stabilization unit. Okay, the patient might come with a major problem, which is definitely taken care by the specialist of the palliative care unit. Okay. In the picture, you can see this is actually one of my units in Assam Cancer Care Foundation. This patient actually came with a severe pain, and we did a IV morphine trial, after which the patient was able to sit. You can see the wife smiling also. So we took a consent from this patient to click this picture, because he was tossing around in severe pain before we actually managed the pain. And we all know about hospice. It ensures the best quality of life and the quality of death also for our patients, for palliative care patients who are definitely terminal. But they do not, admit patients in hospice care who have a long-term survival. Okay, the minimum prognosis has to be 6 months. This is a kind of a hospice care that has been designed for terminally ill patients. Intensive care is not provided in hospices. There are many hospices right now in India. The oldest one is definitely the Shanti Vedna Hospice in Mumbai. There is another branch of it in Delhi also. In Assam, we have this Sacred Heart Palliative Care Center, which is run by, nuns. The nuns are all trained in palliative care. Okay. and people from Andhra and that side of Bangalore must be definitely knowing about Karunashraya Hospice in Bangalore. So this brings us to an important topic, which is very, very relevant when we talk about palliative care delivery and the interdisciplinary team, which is the social work in palliative care. So there are actually three forces that shape the social work role. Firstly, there are certain non-medical social goals, okay? And the teamwork and multi-professional skills that are required to meet these non-medical social goals has to be understood not only by the social worker, but also by the interdisciplinary team that the social worker works with, okay? And at the same time, the force that works towards the expectations of patients or the carers, the relatives of the patient, the friends of the patient, and various other palliative care professionals, including the social workers, would actually give the whole shape to the social work role that is being taken by not only by the social worker, but also by the palliative care physician, also by the palliative care nurse, the chaplain, or the the pandit, or the pastoral worker who's inside the interdisciplinary team. So it is not like the social worker is only responsible for the social work role. It is also that in palliative care, the doctor is also doing some kind of social work. The nurse is also doing some kind of social work, and the other team members are also contributing towards social work. So these are the three forces that generally shape the social work role of an individual. To express the emotional pain and the need for exploring the spiritual pain and the need for finding out the practical help to find an answer to the emotional pain and the spiritual pain are generally defined under the non-medical social goals. For example, the question of why me? Why am I suffering like this today? Okay, I have not drank the whole life. I have never smoked a cigarette. I have never, done anything wrong to anybody. I have never cheated anyone. Why has God done this to me? So this question, this is a spiritual pain of a patient, of an individual, okay? And to answer this particular question and to find out some kind of, shape up a kind of a help, practical help for this particular individual, for this particular patient who's suffering so much in spiritual pain, the social worker or the team as a whole has to find out a kind of a solution to help this person answer his questions. So this is a kind of a non-medical social goal that is very, very important to address. So what are the perspectives of the social worker? Number one, what I as a social worker cannot do. I have to find out my limitations as a social worker. I cannot cure pain because I'm not a doctor. I cannot dress bad wounds, definitely, because I don't know how to do it. And at the same time, I cannot offer appropriate religious rituals because I'm not a chaplain. So I have to see my limitations. But having said this, if I undergo certain minimal amount of training, I might as well take the role of giving some little solution to answer the spiritual pain, perhaps to give a solution, little bit of solution about how to manage these bad wounds, and try to connect with the superior force to find an answer to some kind of spiritual pain that this patient is going through. So and secondly, the social worker needs to see this patient as part of the family and part of the social network that is in and around the family and the patient. Okay. And then, of course, last but not the least, the social worker must understand the implications of special situations of the patient. For example, the mental health legislation of the country. Okay. Many times, because of a long-standing suffering, perhaps, the pain that the patient is going through, it may not be physical pain. It can be a spiritual pain also. It can be an emotional pain also. This patient, opts for euthanasia. So how would the social worker take care of that particular situation? So he has to understand the mental health legislation, the kind of help that this patient might require through a psychiatrist or a psychologist, So everything, the legislations that this country has for these kind of special situations must be understood by the social worker. And the main areas of social work are definitely the assessment, intervention, bereavement, and the wider roles that the social worker might play in the future also. For example, taking the leadership role in the whole interdisciplinary or the multidisciplinary team also. And then when we talk about assessment, it has to be emotional, social, practical, and financial assessment of the patient. And he needs to identify any need for further assessment. He needs to coordinate between the disciplines. He needs to find out any kind of specialist help that may be required by these patients, and then assess at 4 levels: the individual level, the family level, the level of physical resources, the presence of social resources also. So assessing the requirements, the needs of the patient is an important part of social work also. Coming to the interventions, when you have assessed, you have to design interventions. And these interventions will have to be aimed at patients and families who are in need of help to cope with their situation. Basically, you have to provide the adequate and appropriate information, not only about the disease or the situation of the patient, but also about other important things. For example, there are many, facilities provided by the government. Okay, in Assam, we have health facilities like the Atal Amrit Abhiyan card, and in the national level, we have the Prime Minister PMJY, as it is called, the Prime Minister Jan Kalyan Yojana or something. So these two cards are available to patients who fall under the BPL category or the below poverty line category. So this is an important information, and those are to be made available to such patients by the social worker. That is a very important role that the social worker generally plays. Okay. And then facilitate proper communication to reach a solution, to imbibe the confidence to act. For example, suppose the social worker is working just as a solo practitioner model in one of these hospitals. She or he doesn't have a team to complement her. But then the oncologist or the nephrologist gives certain kind of a prescription, or advice for a kidney transplant. I'm just giving an example. And the patient and the family is in a fix, what to do, what not to do, So the role of the social worker out here is to imbibe the confidence to this particular family to take appropriate action, to take the decision of whether to go for this or not. Okay. So of course, those will be definitely, not only to counsel the patient to go for a kidney transplant, but of course to, help the patient and the family take that particular decision of going for that operation or not foregoing that particular decision. Okay. And then of course, facilitating the required resources, facilitating the bereavement support, everything. These are all interventions. Bereavement has, it's a huge role of the social worker, because in palliative care, when we have people, dying patients with us, the social worker generally has a huge role to play in bereavement support. Okay, maybe one-to-one bereavement. It may be, bereavement groups. It's not much seen in India, but in the West, there are bereavement groups, support groups. Okay. Bereavement counseling is a specialized form, a specialized subject per se, which many people go and specialize in, and they actually dedicate themselves for bereavement counseling. An extended grief counseling for those people who might need extended support during a loss. And then, of course, the special needs of, like, losing a child or a young adult, trying to accept the situation, the social worker generally plays a very important role. And then, of course, there are wider roles for the social worker, supporting the doctors and nurses to carry out the social work task. Doctors generally are focused at their work, even when we are palliative physicians, and we understand, must play a social work role also. We are focused at physical issues of the patient. And it is the social worker who generally reminds us about the social work role that physicians must also act upon. And then, of course, the nurses. It might also extend from simple advice to a leadership role in the IDT, as I already told you. And it should be involved in a day-to-day decision-making on management of patients also. Responding to suicide threats. I remember, an incident where there was a frantic call from a neighbor of a patient, and it was an unknown number in the helpline, and we were the nurse who had the phone was busy with one of the other patients and unable to take the call. And next day, we came to know that the patient in that particular neighborhood had committed suicide. So responding to suicide threats are also very, very important. You have to give that responsibility to somebody who can actually attend to these calls. Okay. And then deciding facilities for child patients, working with interpreters. These are very, very important roles of the social worker. Community liaison, as we already talked about, like routine general contact with people, creating a care package for patients, facilitating the resources that are already present in the community for that particular patient. You can see that happening very much rampantly in Kerala, because they have a neighborhood network of palliative care. Taking care of children's education, those children who have lost the main person in the family, who was the main breadwinner of the family. And then, of course, facilitating the job for a family member who's lost like the daughter getting the job of the father, facilitating all those things for that particular. It also comes under the wider subject of rehabilitation in palliative care. And then awareness generation is one of the most important role of the social worker. User involvement, involving the family members in the care process, establishing a long-term relationship with the bereaved family, because the end user is definitely the family and the patient. And that is the feedback given by the family members would actually determine how we have excelled or we have failed in giving that particular care process to that particular patient. So in conclusion, the field of social work in palliative care is definitely newly emerging one in India. It's very, very rampant. It's very, very specialized outside of India, abroad. I have had interactions with, leaders who are from the social work background and have excelled in their work, going through all these stages and coming to a leadership role. So the challenge is not only to demonstrate the expertise in psychosocial assessment and intervention in the advanced illnesses, but also to take a leadership role in the development and research of new models of care and specific psychosocial interventions for patients and families. So I do not know how many social workers are there in today's session, but I'm sure that I believe that we all are delivering some kind of social work to the society through palliative care work. It cannot be just a physician or a nurse or a chaplain for that matter. It has to be, it has to come from your heart. And then you come to know, your goals, how you perform for the betterment of the patients. So thank you very much for giving a patient hearing to me. And if you have questions, I'll try to answer them. Thank you.
Thank you so much, ma'am, for a wonderful presentation.
Ma'am, okay. Is there anyone? Is there anyone? I think someone was about to ask something.
Could I ask?
Yeah, definitely. Yeah.
So I put up the question in chat. This is on the point of the types of interventions by social workers. So the second point under that was facilitating proper communication to come to solutions. I was trying to get an idea of, like, are there cases, like what communication between whom, what kind of solutions?
Okay, so I'm sure you're going to have an elaborate session on communication skills. Okay, how you communicate, what is the information to be given, and how much information is to be given, what you do not have to speak, how much you have to speak. So I'm sure, Rajlakshmi, there would be a lot of interactions between the participants also. I really don't want to uncover that thing. If I'm allowed to, I can go on speaking. It will take me another half an hour. But then, communication skills for not only for a social worker, but most importantly for everybody working in palliative care setups are the key to giving solutions to any kind of a problem. Okay, so you have to understand breaking bad news. You have to understand information sharing. You have to understand the hierarchy of giving information. For example, the communication of terminality of disease has to be communicated through the lead. It cannot be that I am a nurse and I've come to know that the patient has 6 months to live. So it is my moral responsibility that I have to give this information to the patient or the family so that they can plan ahead. It cannot be like that. There has to be a consensus building between the team members. Most importantly, everybody has to give their opinions about this particular case, that it is terminal. These are the reports that are going towards the diagnosis of the patient being terminal, and henceforth we have to put this across to the patient and the family. So this is what I generally mean by communication, by giving the correct information and the bit of information that is required at that point of time. So you will have sessions on communication skills, and that would be very, very elaborate. I hope this answers the question.
Yeah.
I think there are questions about the role of psychologist and occupational therapist. All those questions, I think in future sections, we have a detailed classes on it, on the particular role of each in the IDT. So we can further we can have some questions related, detailed clarification on this. And ma'am, yesterday we had a question about occupational therapist role in the IDT. So can you just share a brief view on occupational therapy?
So I can see a question by Dr. Ankita Sharma. Can you please highlight the role of occupational therapist in palliative care? Yeah, so occupational therapists are nowadays very much required for geriatric care patients. Okay, correct me if I am wrong, but I can see a lot of occupational therapists working with geriatric care patients, because they are many of them are very old aged. They are unable to walk. They have arthritis. Many of them have spinal problems. So occupational therapists have a huge role to play in palliative care. Also, the geriatric care population, the geriatric care specialty has a lot of merging parts with that of palliative care. We cannot really say that geriatric care populations are palliative care patients, but many of the palliative care issues are also seen with those of geriatric care patients. And that's where occupational therapists are definitely a must in a interdisciplinary team when we take care of geriatric care patients. For example, many of our patients in cancer or in long-standing diseases, which are going to be terminal, they require a lot of help from the occupational therapist. For example, if they have, if a cancer patient who is around 70 years old is also suffering from severe arthritis, would need an occupational therapist. He may not need a rheumatologist or a person who's or a doctor who's specialized in arthritis or a joint specialist for that reason. He may need the help of the occupational therapist. So that is where the role of occupational therapists come in. It's the same way you can actually appreciate the role of a physiotherapist also, the role of a nutritionist or a dietitian also. Okay. I can actually share one of my experiences with one of these patients who was a cardiac failure patient. She was in her 80s, and has had a heart attack or a cardiac arrest. And then she was all right after some time. And then, after a period of hospitalization, she came home, and then we started giving her that care. But I felt that, she was not doing well with the kind of physiotherapy that we were trying to give her. So, we went ahead to find out somebody who was more specialized. And then I came across a physiotherapist who was specialized in sports physiotherapy, and then he started giving her sessions on mobilization, very simple sessions on certain kind of basic, I think, mobilization techniques. And after a month of his regular sessions, we could actually see her walking. She's passed away. I'm talking about, this patient who passed away in June last year, in 2022. But, I had seen a major difference. At least she didn't have to suffer because of her mobilization problems, because this particular specialist sports therapist had come in. So, you can actually, the important point here is that you need to identify the problem that the patient is going through. You must not actually shove aside that, take care, he's become old, so he will definitely have. There are definitely going to be a lot of solutions. Those solutions may be very, short living, of very small duration, but then they do give you good results. Yeah. Anything else?
Nothing else. Ma'am, one more question is there. Should a psychologist be a regular team member or only with the referral? So,
okay.
yeah.
This is a dicey question. So my advice would be, whoever is in the palliative care team, they should have a good hold on palliative care issues. I'll give you a small example. So I was working in this cancer hospital, who had very good departments, all sort of, it's a very great hospital in the Northeast, private cancer hospital. And there was this physiotherapist who would actually come in, not a regular physiotherapist, or the visiting physiotherapist. So, so there was a mishap. So what happened is that this particular patient had a lot of bone metastasis. It was a cancer of the prostate with all kind of metastasis in his bones. And this physiotherapist, in order to make him mobile and feel strong, had actually gone to a different level to, the intent of the therapist was really good, but then it actually landed up in pathological fracture. Okay. So this particular physiotherapist must have had some bit of training of palliative care, where he or she must, understand to accept that we may not have to do everything to give relief to the patient. Sometimes just very small bit of exercises, very superficial massages might work wonders for a palliative care patient. Okay, so this is where you need to be careful. Okay, please be sure of delivering this in a very non-threatening way, the information that everybody who is working in this interdisciplinary team of palliative care should have some bit of understanding, some bit of formal training in palliative care. So, once this particular psychologist understands what not to say, what information not to give, because that is very important, that will actually save you guys from a lot of trouble. Okay, so that is my advice. Anything else?
I think we are running out of time.
Yeah.
So, there are any burning questions?
I think we can have it in the chat box. And is there anyone who wants to ask?
We will be having a conversation regarding communication and psychosocial support in the upcoming sessions. We have scheduled that. I think we can wind up today. Thank you so much, Sanghamitra ma'am, for joining us today. It's always a happiness to have you on board. Thank you so much. And thank you all for joining us today. I have shared the feedback link in the WhatsApp group. Kindly go through it and fill it. Thank you all. We'll see you on the next session. Bye-bye.
Thank
Thank
you.
you.